Carey has worked as an NHS GP now for a couple of years. I'm skipping over the book that they wrote now. Areas of high socio-economic deprivation, including homelessness services. She is the chair of the Scottish GP project, comprising of clinical and academic GPs working in 100 practices serving the most deprived communities in Scotland. And current role is senior medical advisor to Scottish Government on health inequalities. She's also the past chair, I was about to say media, but you're not, the one between of the Royal College of GPs of Scotland, and is a passionate advocate for the particular role of general practice in addressing health inequalities. So please welcome Carey, and I will pass over to your hosts.
Welcome everyone. It's my job to kick things off because we're really running this as a full question and answer session rather than as a formal lecture. For those of you who don't know Carey, I suppose our opening question to Carey is, can you tell us about your career journey and the leadership roles that you've had, and that helps us get into finding a bit more about you?
Okay, I never really had a particular plan into my career, and I think I've sort of largely fallen into roles because I tend to be a bit outspoken. That's been my reflection over the past 25 years. Not that I've not enjoyed them, and not that I've not really felt grateful for the opportunities that I've had. I don't think I ever had a particular game plan. So I qualified in '97, Aberdeen University. And then I did a self-construct GP scheme, mostly around kind of Edinburgh, Glasgow, and Ayrshire. And then I did one of the men fellowships actually when they still existed, the 2-year ones, and I did an MPhil in law and ethics at that point because I really enjoyed medical ethics during GP training because it wasn't something that we had anything of in undergraduate years. I got really interested in advanced decision making at that time as well. That's what I did my thesis on. And then I came to the end of that. I became a GP partner and I was practicing Midlothian and a GP appraiser, but was also really interested in patient autonomy. So I started to work with the college around about that time and became one of their executive officers in patient and public engagement, which was an interesting role for a couple of years. And then I made a big switch and I moved from being a salaried doctor to, a partner to being a salaried doctor in homeless practice in Edinburgh. I think just for the change of it, and also I think that feeling of wanting to work in a part of the NHS where people's needs were really great and you felt you could make a difference. It was very, very different to working in partnership, and it was pretty overwhelming, to be honest, when I started working in the homelessness, but it did change my life, and I don't say that lightly. I think the people that I met when I was working there, the patients that I met when I was working there definitely changed my whole view of what you could do as a GP, and I got really interested in a lot of different things when I was working there, particularly inclusion, health inequalities. But also got really interested in care planning for people who were vulnerable and complex needs and building interfaces of care across the primary and secondary care interface. So I did a local leadership role as an anticipatory care planning clinical lead for 5 years. And then that kind of led on to being the interface lead within the college, and then ultimately, and somewhat reluctantly, the chair for 2 years, from 2017 to 2020. And then when I came to the end of that time, I took up the role as a head chair, and I've been doing that since 2020. And I think along the way, you obviously meet a lot of different people, you forge a lot of interprofessional relationships. Scotland's a small place. And you often re-meet people in different roles, and the role within Scottish Government as an advisor was created last March, I think just in recognition of the fact that Scotland's health inequalities are the worst in Western Europe, increasing recognition of the role that general practice can play, and so I sit within the primary care division of Scottish Government and advise them on policy development, which is a whole new world of learning how another culture of an organisation works. So that's kind of what I've done throughout my career, if that's a journey, I suppose it is.
That's mine. What was I saying? I mean, there's so much in there. There's so many different bits and pieces, and yeah, like you say, it's not a linear straight line, but actually, that I think lots of us probably in the room can think back to the sort of circular bits and the bits that you maybe didn't expect to come on, but actually the learning that you get from it's really valuable. So thank you for sharing that. Just taking one step on, Jules, you mentioned several leadership roles, the RTGP and obviously Ireland's Scottish government. What have you learned from those leadership roles? So yeah, what's it you've learned that you kind of have taken from each role's role in a sense?
I think the biggest thing that I have learned is that, and we will all be familiar with this, it's all about relationships. So you can't really make any progress or argue for change if you don't invest in the relationships, even if the relationships are challenging. And they often are, because sometimes you're having to work alongside people who hold quite different views. So I think the investment in relationships, so that you've got common ground where you can have common ground, so that therefore you can be critical friends when you need to be critical friends, just means that the chances of success are higher. And I think, looking back to when I took up the role of the college chair in 2017, that was a really difficult time for general practice. The new contract was being negotiated. There was a lot of uncertainty. There was quite a lot of division within the profession. Relationships felt a little bit fractured between the college and BMA and between government. And the new contract was announced 2 days into my chair. And so suddenly there was this huge kind of thing I had to get my head around and work out, what does that mean for different parts of the profession, and how do I understand what everyone's needs are in all of this, because as a chair you're trying to represent as many different types of general practice as possible, whilst recognising that it's not possible to do that. You just do the best you can, and you take advice from your executive officers and your deputy chairs and members to get that advice. But ultimately, for me, when I started, I thought my number one priority for the first year was rebuilding relationships, because without that, we're just not going to be in the room, and we're not going to be able to influence, and we're much stronger together. So even though we have got different roles, we can be quite complementary in that space. I think if we could find a way to find the things that we have in common. So I think building relationships feels really key. I think the other thing that I've learned as well is that although it has felt scary to be the challenger, and I've often been the challenger in life, look back at my report card for primary school, like it wasn't, those words weren't used, they were derogatory language used. Use that. But I think, if you feel that you've got something to say and it's going to be difficult, you need to say it. You need to try and package it so that it's kind and that it's true. But I think if you don't say it, you'll regret it. And I think often what I find is that even though you say stuff that's difficult, people will often come up to me after the meeting and say, "I'm really glad you said that, I agree." In an ideal world, they'd say it in the meeting. But I think you need to. I think you do need to say the hard stuff if you want positions to change. So I think building courage around that has felt like a difficult thing to do. I'm naturally quite conflict averse, but I actually at work now I realise there's just some stuff that you have to say if you're in an advisory role or a leadership role, because it's your job, to do it on behalf of patients, to do it on behalf of the profession, and to use your voice to influence, particularly on behalf of people who don't have a voice. So I think that for me, those two things have probably been the things that I've learned the most. And often people will ask you into their group when you say the difficult stuff, when you kind of expected them to exclude you, which is quite interesting, which is good. But I guess that is maybe just practicing how do you use language that is meaningful to the people that you're speaking to, because different language will land in different ways depending on the organisation. So if you're speaking to the college, it's about quality. If you're speaking to kids, it's about safety. If you're speaking to PHS, it's about population health improvement. And if you're speaking to government, it's also about things like economically viable and sustainable. So there's lots of different ways that you can skin a cat if you've got a message that you need to share.
Thank you very much. So as I look around the room, I can see a lot of GPs, different stages, different in terms of life and career, and I suspect it'll be huge interest as we look around there. So I think we're really keen that this is not just an observed conversation, we want it to be a collective conversation. So, we're at the point where I think it would be really helpful to open up to the floor if anyone has any questions or comments. Just like to pop your hand up, and indeed anyone online, do feel free to do just that. Don't be scared. We're all for that. We've got a ribbon money.
Obviously, with things that you're working on, that we're all working on, it comes down to more things a GP could do better. How do you find, or how do you think it's best to find the balance of what GPs could do better in terms of things like health inequalities versus not asking busy GPs to do more?
I think that's a really, really important question. So I think one of the things that I feel is really important around health inequalities is I think traditionally it's been perceived as a special interest topic, whereas it's core NHS work. It's what the NHS was set up for in 1948, but I think that it's convenient to think of it as something that just happens in the deep end. But it doesn't, of course, just happen in the deep end. Every practice has got deep end patients registered with them, and often actually practice people living in poverty, but also within the context of a wider, more affluent area, have even worse outcomes than people living in areas of blanket deprivation. Their services are even harder for them to navigate. So I think there's something about winning hearts and minds to say this is everyone's business. It's difficult, it can feel a bit overwhelming, but it's not a special interest topic. It's something that GPs can do really well, but we need supported and enabled to do that, because it's impossible to do an awful lot more or an awful lot differently within the current constraints of workload and workforce. So there's something for me about how we train people to feel confident and competent, and that inclusion health really needs to be embedded throughout the undergraduate, postgraduate curriculum, so that people come out at the end and think, I could work in any area, I feel confident about this. It's not something you're going to have to do a CPD to finish your training, and I know that training is overburdened as it is within a 3-year course. That's a whole other discussion. So there's something about enabling the workforce to feel this is something I could do if I wanted to do it. I think there's also something about creating resources that are easy to use for practices and translating what feels like quite a big nebulous topic that's quite hard to grasp. What does health inequalities mean? What does that actually mean in the practice? And thinking about, well, what it could mean is an inclusive registration process where you don't insist on photo ID or proof of address. And or I'm not thinking about a DNA policy, but thinking about an exclusion prevention policy. I'm thinking about how do we hold people in a sticky system rather than excluding people, or how do we create appointment systems that really support relational continuity for the people who really stand to benefit from it the most. And that's often even more important in defined areas, but it's important everywhere. So there's something about looking at what we already do and applying a health equity lens to it so that we can do it slightly differently. But I think there's also something that's really interesting around the role of clinician advocate, which isn't something that we teach, I don't think, in postgraduate training or at medical school, but actually quite a lot of people are interested in how they can effectively advocate for the patients or their patient list or for their profession, but don't necessarily know how to do it. And again, just creating some simple resources on what good advocacy look like. It might just be a petition in your waiting room, or it might be inviting an MSP to come and see around your practice and just see what happens on the front line, or it might be writing an article carefully worded for the local press, or it might be raising a question in Parliament, or so it'd be a whole lot of different things. But what I think is really interesting around that is that even that can feel quite overwhelming. But when you test out little bits of advocacy, it can bring a lot of joy back into work, which is quite often missing because I think we all feel really overwhelmed. So there's something for me around if you're able to get alongside patients and feel like you're using your voice, even when we often feel that our voices are not listened to, that we're not valued, that we're the lowest part of the pile of the NHS. Imagine how a lot of our patients feel. And when we use our voice collectively or as part of a practice to do something really simple to advocate on behalf of patients, it can feel really good. it can bring a lot of, I think, joy and well-being. There's lots of articles that are written about advocacy and reducing burnout. So I think there's just ways of making it feel attractive and doable, rather than a huge thing to add on to what we're already doing. And of course, there is a lot more that we could do, but only with additional resource, meaningfully. So there are some interesting pilots that are happening in Glasgow that I'm involved with my Scottish Government job, called the Inclusion Health Action Fund. It's only going to GGC practices because that's where 80% of the most deprived practices are in Scotland. And they're getting a little bit of additional resource to look at 3 different things. One is training up workforces in health equity. So that might be trauma-informed training, it might be suicide awareness, it might be mental health first aid. There's lots of different things that people have chosen to do, and then taking that learning and embedding it into the way that they design and deliver their service. One of them is around meaningful community engagement. So how do you connect with your patients, whether it's focus groups or peer support groups, or seeking ways of meaningful feedback from people with lived experience. And then the third one is, how can you think about the people that are missing from your service in a different way? So the people who aren't routinely turning up, particularly serial non-attenders, who have often a very high risk of early mortality. There's a lot of research out about that. Just thinking differently about, are they the people actually that we should be worried about, not the people who successfully navigate our service. So missing this is really interesting, and often I think, if we're honest, when someone doesn't turn up, it's a chance to catch up on an otherwise undoable day. But if you put additional resource into practices and combine that with some training around what missing this means and how you can target the people that are most at risk to do things slightly differently, it doesn't have to all be the GP that's doing it. Again, that can feel like just a really good use of generalism and general skills and general practice. I think there's lots of different things we can do. That's a long answer.
Continuity of care is achievable in general practice nowadays, and I'm an ancient GP, so I won't go, but I value the continuity of care I had in working in the same practice for 30 years, looking after the same patient and store. And we know that it reduces morbidity and mortality as a concept. And so where is that sitting as a priority within your discussions at this levels?
I'm so glad you asked that question, because I completely agree with you. I have been aware of, over the years, lots of discussions around continuity of care and how important it is, and yet there's kind of disconnect between huge evidence base around relational continuity of care between a doctor and their patient, and it is specifically around relational continuity of care between GPs and patients that the evidence base is from, largely, overwhelmingly. So reduce morbidity, reduce mortality, improve patient experience, better safety, better use of wider NHS services, reduced attendances at A&E, reduce workload in practices, improve practitioner well-being. If this was a drug, we put it in the water, and yet we are still obsessed with a routine health service that's about any place, anytime, anywhere. And speed of access. We've become so fixated on speed of access that we have sacrificed continuity of care. So with that in mind, I decided to write a paper from primary care division of the Scottish Government. Why is continuity important? What does the evidence tell us? What does that look like? Or what are the challenges at the moment in our current landscape of general practice and primary care? And what are the levers in the system to try and get to where we need to be if we think that this is important? And a lot of people do, including the CMO, interestingly, who's just set up a subgroup on continuity of care and is really keen to try and make this happen. So I've done a paper and I've looked at the evidence base, which we touched on there. And of course, we know what the barriers are. We've got a declining GP workforce, less full-time equivalent, less headcount. We've got less than full-time working within that. We've got rising demand. We've got multidisciplinary team models, which are great for many things, but they fragment care. And we've probably just got a cultural shift where the perception of someone coming back to see you is maybe viewed negatively. And I hear that from lots of trainees, that it's not included in training as something that is celebrated and encouraged. It's more encouraged to give someone a management plan and not necessarily be seeing them back. That's maybe considered not as good medicine. So there's so many things that are fighting against relational continuity of care, including, I think, a recognition of the emotional labour of what relational continuity actually means. So I think if you're working with people, particularly maybe more so in a deprived area, relational continuity of care we know is particularly important for people who are older, frailer, have multimorbidity, have complex long-term conditions, have got mental health diagnoses, addiction problems, and who are living in socioeconomic deprivation. So they are the groups of people who benefit the most from relational continuity, and yet being in a long-term relationship with people who maybe experience high levels of adversity or trauma is not easy work. It has an emotional labour attached to it that we don't talk about. We don't talk about it. And so if we don't talk about it and we don't think of mechanisms to support us in that work, to recognise it, to give ourselves time, to give ourselves access to reflective practice, balanced groups, recognising the psychodynamics of different consultations, then we develop maladaptive coping strategies to the emotional labour of that work, one of which is not celebrating continuity of care. So there is an incentive to pass people around if they are perceived as more challenging or difficult. And with other maladaptive coping strategies as well, seeing people in twos, behavioural contracts, putting folk off the list, making it difficult for people to register. All of that is understandable because we live in a system that, or work in a system that feels too hot and too unsafe. And so that's what happens. People develop coping strategies to deal with that. And if we want relational continuity, we need to recognise and support the emotional labour that that brings as well. So I think that all of these things are fighting against it. And then when we think about the levers in our system to achieve it, there's lots. So again, we can think about it from a quality improvement perspective. We've got college, we've got fantastic resources on continuity of care, particularly that have been worked through down south, much more so than in Scotland. So the Exeter research team, Dennis Pereira-Gray's team, have done a lot of work with the college and NHS England and the Health Foundation around continuity of care, and there's a dedicated part of the RCGP website that people can use, resources about how to do it, how to measure it, how to get your patients on board with it, how to get the whole team to sign up. And the other organisation interested in quality, of course, is Healthcare Improvement Scotland. So we've got all sorts of collaboratives from Healthcare Improvement Scotland around things like access, why not have one around continuity. And then we've got cluster working. We could be actively supporting clusters in that space if that was of interest, if that was felt to reflect local population needs. We've got, in terms of the BMA, we'd be interested in the workload reduction that it can ultimately bring and the practitioner well-being. It will have impacts on recruitment and retention, I think, if it's seen as a way that is a more enjoyable and rewarding way to work, which is what the RCGP tracking survey showed as well. But I think also we have contractual levers, and interestingly, the manifesto commitments for the Labour Party down south include specifically incentives around continuity of care. I don't know what that means. I don't know what the detail of that is, whether it means we will encourage practices to measure it, or whether it will be included in QOF, because of course QOF still exists down south. But having a named GP is not enough. You need to have the whole team signed up to what that means, everyone singing from the same hymn sheet, the care navigators with their the first point of contact with the practice, being able to explain to patients why continuity is important if people feel able to wait. You need to do lots of work with your patient population as well, but you also need to find ways of measuring it using the validated scores like usual provider of care, or the SLIC score, the St Leonard score, which is from Dennis Pereira-Gray's practice. So measuring it helps us understand it and know whether we're improving. When you get to 50% continuity scores, where patients are 50% or more likely to see the same clinician, then you start to see improvements. And when you get to 75%, then you see much bigger returns. So there's lots of stuff that we already know, and it should be really useful pulling it all together and then sharing it with the different groups that might be interested in how we enable that. So I think different organisations have all got different roles to play in how we can make that happen if we think it's important. And it is important. Thank you.
Hi, I'm Georgina. I'm an SCP that's about to finish. I had the opportunity to chat to you the other day in an interview. The question that I wanted to ask was around whether you think that encouraging more widening participation from different non-traditional groups or medical students can help in terms of the things like the health inequalities that we deal with in Scotland.
Yeah.
Do you think that that has an impact? Do you think it makes a difference recruiting people from different communities or non-traditional?
Yeah. So in short, yes. I think that medicine is one of the least socially kind of diverse professions that we have. And we need to have a workforce that looks after the population that it cares for. And so I think writing participation is really important. It needs to probably start at quite early on in school. And so things like the GAP programme and the REACH programme, which I know the faculty support, is really important in helping people believe that could be me. Just because I'm at a school that doesn't traditionally make doctors, that doesn't mean that can't be me. I think writing participation is really important, but there are lots of caveats to how you make it work. So having a tick box exercise that says you've reached X% of writing participation is meaningless unless you also put supports in. How do you help people flourish and thrive and graduate and then stay on in the workforce at the end of the day? So I think I'm not sure how well we've done the second bit. I think the widening participation agenda is very hurt. And so a lot of universities are obviously keen to show they can do that, but I'm not sure how well we're doing. Genuinely not sure. I'd be keen to hear from anyone who's got more experience on that, how we're doing it, supporting people who come from different backgrounds, who need more support academically to do a really difficult course. Otherwise it feels like we're setting people up to fail, which is even worse. So yes, and
We have an online question. Amy will read it out for us.
This is from Gemma Proven, who says, "It's lovely to hear you speaking, Carey. What would you advise us where we are passionate about general practice and health inequalities, but I think feel the most undervalued that I have ever felt within the NHS and Scottish Government, facing huge bills and uncertainty about practices surviving, dealing with constant patient complaints, having to practice more and more defensive medicine as patients threaten us with being sued and with no extra help in sight."
So I think it moved me a question at the beginning about what do we wear, which I thought, well, I can speak to that. Something that doesn't feel as absolutely because I think that there is no getting away from the fact that I don't think it's ever felt as difficult as it feels just now for all the reasons that we know. General practice has been very severely impacted by a pandemic and now by cost of living crisis. And by a kind of constant feeling, I think, of being undervalued as part of the wider NHS family. And I think just morale is at an all-time low, and there are battles on every front. So there's no easy answer. I think it's really important that people support each other as much as they can within their own teams. Just simple things like spending time with your team, having coffee with your team. I used to bring fresh herb flowers into Craig Miller, particularly when I was feeling really demoralised. And I just used to put fresh flowers on the front desk and on my own desk so that I could look at them during the day and think, I'm lucky I've got fresh flowers on my desk. And patients used to come in and go, oh, look at those lovely flowers. And it changed the feeling of the consultation. So it's simple stuff, making people a cup of tea, investing in your team, I think, and making sure that you find some time to come together, even if it's pressurised, but also looking after yourself, which I think is difficult. A lot of people are talking about maladaptive coping strategy. I think a lot of people, are making the decision that it just is too much, reducing the amount of patient-facing time, and of course then that feels. I feel guilty for not working in a practice at the moment. I know that people feel guilty when they cut down their patient-facing time, but it feels like the only way to be able to keep doing the job. So I think that, having access to things like coaching, if you can get it. I know that NES do coaching, I know that the college has looked at coaching. I had coaching for a while, found it really, really helpful just to have a safe space that was non-medical and not really affiliated with any particular job. where I could talk about all the stuff that felt really difficult to talk about and cry, ready to cry. I had reflective practice for 5 years during when I was working in homelessness. I find that very professionally life-saving. I think in an ideal world we would all have access to reflective practice. It shouldn't just be something that's for the lucky few. It shouldn't be something we have to pay for. It shouldn't be something that we have to do in our spare time. It should be our working week. It should be a recognition of the emotional labour of the jobs that we do. This is what we do to keep ourselves going and celebrate our enormous skill in being able to connect with people at human level, because it comes at a cost. And I think if we as a profession were able to say, this is how seriously we take human relationships, we are a relational specialty, it would attract people in and it would help people stay. So I think there's lots of stuff we can do to try and protect ourselves, try and support our teams, but I think going back to the advocacy point, I think having a feeling of where can I make a difference, where can I have some control, where I feel like I have no control, also feels really important, whether that's advocating on behalf of patients or whether it's getting involved in the work of your local faculty or your local LMC, whether it's being very careful about who you vote for. You know, there's all sorts of ways that we can make our voices heard. And I think that just thinking, well, what can I do with the voice and the privilege that I have? It just makes me feel a bit less out of control is also important. And I think just feeding back to the people who are representing, or who feeding back to people who are representing you in decision-making roles is also really important, so that voices from the front line are being heard and are being represented and fed into policy making, decision making. So this kind of conversation is really useful, for example, in my work with Scottish Government. So none of those are quick fixes, of course, but hopefully some.
Sorry.
You've been heard on the line, you know, online.
John Kennedy, really enjoying your top tips. One question that comes to me is part of looking at the future of general practice, and there's a critical question in support of the label. But I wonder, while we see significant numbers of our specialist colleagues increase, and all for that, why is it that, or is there a way that we can work towards increasing the actual number of general practitioners headcount? We'll take for another. Because especially if you're doubling the specialists, but really not creating more positions for GPs, situation risk getting worse, even with MDT, ANP, all these people, great as they are, we kind of lack GP.
Yeah, no, I completely agree. And when you look at the ratio of GPs to consultants, it's almost reversed in the last decade. It's very, very stark now when you see the workforce trends across the whole of the UK, including in Scotland. So absolutely, it's great that we've got consultants doing the work that they do, but it is the most expensive part of the NHS to receive care. So if you want realistic medicine, if you want value-based healthcare, if you want NHS sustainability, if you want an NHS autonomy, you need the generalists working out in the community. And if you want MDT models of care to work well, you need generalists working out in the community. They are utterly codependent on each other. So I completely agree with you, and I think, maybe I'm being optimistic, but I think that the penny is beginning to drop, that it doesn't work without GPs. It doesn't work without GPs. And I think, you know, the college does a great job in selling the unique selling points of general practice. What is it that only we can do? I think we have been, we've been very humble in singing our own praises, and we've been very welcoming, which is great, to lots of people coming into our specialty. But I think we've kind of, now is the time to be saying, this is the stuff that only we can do. Really, you know, we need to be in the leadership positions, in the strategic positions, and the influencing positions, but also dealing with complexity and multimorbidity, managing risk, doing relational continuity of care. None of that stuff is possible without medical generalists. It's just not possible. And the secondary care is already becoming overwhelmed. So I think there is a renewed interest in GP workforce planning in the last few weeks and months. that I've been involved in discussions around, which I'm very glad of, because it feels like it's long overdue. Best time to plant a tree 20 years ago, it could be said. But we need to urgently grow the GP workforce, and we need to have meaningful workforce planning that is not headcount, it's full-time equivalent, in the same way that every other workforce is planned, including across the rest of the UK, because headcount workforce planning is meaningless. So I completely agree with you, and I think that there are now much more active discussions around the urgent need to retain our workforce, number one, and to recruit into our workforce for all the reasons that we've talked about. My feeling is that relational continuity is perhaps a hook, because that's where the evidence base is. It specifically is about relational continuity between the GP and patient. It's not the same as informational continuity, it's not the same as managerial continuity, no matter how much people might like to translate the evidence base and try and put it elsewhere. It's not what the current evidence base tells us. I'm sure there is an evidence base for continuity with other types of clinician, but we don't have it yet. So based on our current evidence, we need to urgently grow the GP workforce if we value continuity of care for all the reasons that we've talked
Probably what they
I suppose it's a bit of a rewind, Carey, and go back to this, the dilemma that there still exists about access versus continuity.
Yeah.
And I think everyone in this room will engage with the benefits of continuity. But I was reading on social media a practice conveying very sadly that they can only deal with emergencies. And then I observed on the community group the backlash from that and what people were conveying. So we've got a real challenge, and I know you referred, and there are toolkits out there to try and engage patient groups with you at practice level. Lots of practices as the practice I still associate with, as a very active and effective patient group, can get through this challenge of getting patients on board. Now, I know when you were chair, one of your priorities was to try and promote public conversation and to look at other ways of how we can actually pull the public back in to start to value us again, which absolutely the evidence suggests that we don't. So I'm really interested in your thoughts now, a few years on, about where we are, where we got to with public consultation, how we can bring, apart from at piecemeal levels within practices, but actually there's not a huge amount I can see of evidence that that's particularly successful, and we all engage with the benefits and the things that we can do to enhance continuity. How inevitably we persuade our patients that that's got to be at the expense, to some extent, of the immediate access that they demand. And I know that, interestingly enough, there are differences across the different demographic groups, and the groups within deprived areas, they have different expectations, different needs, different acceptability of the service that's available to them. Where can we go with that? Because actually that's going to address the morale that the online person refers, or I can't remember who it was, about how they feel, how undervalued we feel. And at the end of the day, we're undervalued across the board. I'm particularly undervalued by our patients now. That is really, really demotivating at best, but soul destroying. You've been a GP for as long as I have. So it feels like there's two layers. I'm going to say I'd like to don't forget it. One is the question around access versus continuity, and then one is the question about almost changing the public culture around Amazon Prime delivery of healthcare, to use another analogy. So I think obviously there will always be a need for speed of access for urgent medical issues, and it's about changing the narrative around the non-urgent issues, which could benefit more from seeing the same person, because we don't have to repeat their story, because it's safer, because it's of higher quality, it's more efficient, all these things. So I think that the toolkits can be useful, but that alone is not
going to change the kind of rising public opinion around. We just want it dealt with now. So I think when any continuity work is being trialled in Scotland, if we get to that point, we are probably going to have to do a proportionate continuity, as in who are the cohorts that really benefit, and we focus on them, and we really try and encourage relational continuity where they don't need to be seen urgently that day, and we do lots of work around supporting teams and having an equitable distribution of the patients linked to the doctors in the practice, so that nobody is overburdened by the more challenging clinical scenarios and all that work. Public engagement around how we value and how we keep our NHS sustainable is still an ongoing issue. I think. I don't think we didn't get where we wanted to be during my time as chair. I think we had some commitments from the Cabinet Secretary at the time that this was a good idea. What we were asking for back in 2017-18 was a cross-party approach or a cross-party conversation around the sustainability of the NHS in its 70th year, that would be led by politicians across the board and supported by professionals, so that it was a joint message, and that we would be supported in that work by organisations like the Alliance in terms of how that landed. And that it would be around what can the NHS be expected to do and what has it to stop doing if it's to protect its core founding principles 70 years after its inception. So it was a difficult conversation. It was a kind of a rationing conversation, if we're being completely honest. And that's why we thought it has to be cross-party, because if it's not cross-party, no political party is going to touch a rationing conversation with a barge pole, particularly not at the moment. So I think, there was some interest in that, but interestingly, what I think got committed to and run with, if that's okay English, is was some public education, which is different from a national conversation, on how to understand the new models of primary care. Now that's part of it, but it's not quite what we were asking for. So that was the whole right person, right place, right time campaign, helping people understand why they might be asked questions if they phone the practice and how to navigate new systems, which is equally important, but it's not the same as a national conversation around what the NHS can and can't do. And I still think that the only way to achieve that is cross-party, with professionals, with joined up support across all the Royal Colleges. So it's not just GPs asking for it, it's the whole of Scottish Academy asking for it. And we did get signed from Scottish Academy at the time. And doing it alongside patient organisations, accepting that there are some things that the NHS just can't do if we're going to make sure that healthcare is at its best for those who need it the most. If we go back to the founding principles of why the NHS was set up. I think the other thing that really drives a negative public perception, ironically, access is one, but not seeing someone that they know is another one. So it's about kind of almost like taking that leap of faith to go, I'm really scared to move from an on-the-day access model, which is the only way I feel I can get through the workload, to one where you've got a named clinician and there's a little bit of a wait, and there's a bit of pushback, and we're going to need to wait a few months before this beds in, before people start to recognise the benefits of it and the joy in getting to know someone through sickness and health. And we rediscover that. So it's going to get harder before it gets easier. But actually, the patient satisfaction scores will go up, and the practitioner satisfaction scores will go up, and the workload will go down. But there's a leap of faith to get to that point, and I don't think that the practice can necessarily do it alone. So when we've been speaking about continuity of care and how we get there within the primary care division, there's a keenness that it's accompanied by public dialogue on why relational continuity of care is important and why it would be supported politically, which I think is probably important to help it land. COVID got in the way.
Don't get it. I'm a retired GP. I retired 8 years ago, but continued to work in, still continuing to work in GP. Hopefully to stop this year. Interesting, I did the college exam back in 1983, voluntary, and what was interesting was I went in a course before the exam, And we're speaking about the Black Report, the health inequality.
Yep.
I worked for 33 years in the practice in Dundee, which is one of the deep end practices, but it still is no practice.
Yeah.
Yeah. And so I've seen a lot of change, over many years. Being in out of hours, I see what's happening in daytime practice. I see the sort of patients who are overflowing, into the out of hours. What I see the biggest problem is, what's always been that they share, particularly cash, into general practice. It tends to fall away, despite promises, particularly Scottish government would appreciate it up. And what I've seen was original general practice was very simple. And there wasn't very much in the way of things like investigations. And most of the time there was mostly referrals. But one of the most expensive things to do in GP is either to refer or to prescribe. Anything else is very cheap. So what I saw was that there was a development for chronic disease management. Initially, the hospital tended to take this up. I remember diabetes, and all the patients were going to be referred and be looked after in clinics, and I'm sure a lot of money flowed in. And then, when they knew that they were starting to cost more, everything flowed out again. General practice has become, GPs are now general physicians. There's no general physicians anymore. There's only subspecialties. And I feel that general practice is completely different to when I started, and it's part of the, it's almost like a hospital speciality. We are the physicians, and we're meant to not refer, and not prescribe too much because it's far too expensive. In particularly locally, we've got reference guidelines. Is it not the fact that we should be? It shouldn't be. We should be getting a cut of the, how much it costs for the NHS. Not say it's for general practice, but a cut from the whole lot as to what actually we do in general practice. Somebody, and unfortunately, a lot of consultants in that don't think that way. I know of some consultants who would be very happy for general practice to collapse and take over the care in their specialty, for these patients. Particularly like there's like an American model in that, where nobody goes to a GP. Few and far between.
So yes, I agree. GPs are general physicians and psychiatrists and a whole host of other specialties. And I think one of the biggest drivers of frustration and breakdown in interprofessional relationships between primary care has come from the unresourced work transfer that's come out into general practice over the last 20 years. And the percentage of the NHS budget that goes to general practice in Scotland is less than 7%. For 90% of the consultations.
Nicholas Sturgeon did make a statement that should increase it up to 11%. That was.
Did she? I don't remember her saying that, but certainly that was the college. Yeah, that was definitely the college company. Yeah, but it's not been 11% for a long time, and it's now sitting at a pretty low percentage. I think what I find a helpful way of phrasing that is Scottish Government has priorities around improving population health. Scotland's health inequalities and poor population health is a national shame, the worst in Western Europe. All the global evidence shows that if you want to improve population health and improve health equity, you need a flourishing primary care system, particularly general practice. That's how you do it, because that's the universal point of access where people first go. And that's where you can make the biggest difference. It's not by investing more in hospitals, it's by investing more in the community. So I think that has to always be part of the argument around, if that's the policy intent, this is how you get there. Rather than, and I think always trying to persuade that general practice is the solution. It's not the problem, it's the solution. So it's turning up on its head. And I know we make a lot of noise and we create a lot of problems, and we're probably seen as quite difficult a lot of the time, but we are not the problem. We are the solution to a sustainable NHS and to improving population health and reducing health inequalities. So I completely agree with you that less than 7% of the budget is a complete nonsense. Arguing for redistribution of existing NHS resources is never going to be an easy thing to do, because no one wants to do with less. But as more money becomes available, there's a strong argument that money at least needs to be allocated according to need, and more of it needs to go into general practice. And then you could argue more of it then needs to be proportionally allocated according to areas of highest need. But it's very difficult to argue for redistribution of existing resource because no one feels that they have enough. But we also need to have some difficult conversations about where is the money going, what's it being spent on, within the whole of the NHS. Procedures of low clinical value or extremely expensive procedures that mean we can't do the basics out in general practice. We need to have those conversations. That's all part of the national conversation as far as I'm concerned, because we're trying to fight with our hands tied behind our back with a budget of less than 7%.
Just aware of time, that we did say we'd finish at 9:15. We're about 9:05 now. We've probably got time for a couple more questions. So, anyone still got that burning question? Are we holding back? Yep.
Hello, it's been a pleasure to listen to you actually, Carey. You're a really engaging speaker. I haven't actually heard you speak before, and some real practical tips, I think. But what I want to ask is, I'm Helen McKee. I actually work on teaching on the ScotGem programme. So we're trying to train medical students to be doctors that work as journalist practitioners to try and address some of this deficit that we speak about. But my question was around how do we do that? The bit about sort of training medical students to be comfortable with working in these areas. Do you have any practical tips for what we can do as educators about incorporating some of this stuff into the curriculum? Because even as a GP of many years, I still have a lot of difficulty dealing with some of these areas. It's not something that I'm particularly comfortable with. So what can we do to try and address some of that, I suppose, early on?
Yeah, brilliant.
And the other thing I just wanted to address was working participation that you mentioned, and kind of support that we have for medical students afterwards. I work as a learning participation mentor at the University of Dundee. My boss, I've got a fantastic programme in place at the University of Dundee that supports students that are admitted through contextualised admissions. And so we're really working hard to support students. The other, once they've entered medical school, how do we support them to get through? Because we know there's a high attrition rate.
Yeah. So I'd love to hear more about that. Genuinely, after this, I'd love to hear more about what you do. That would be great to have more awareness of that, to feed that into conversations. But I think your question about how do we support medical students going through ScotGem to come out the other end, feel that they could go and work. Are you asking about in a more deprived area or a more
Because I suppose I have a particular focus working with these medical students, so I'm going to hopefully more generalist in their approach. So what can we do? I mean, this is the perfect cohort to try and concentrate on. We have something called Agents of Change in our programme, meaning that they involve themselves in projects, and there's a lot more community engagement. They involve themselves with third sector, trying to hear those voices, those unheard voices. So we do a lot of it, but I just wondered about the tips for doing better.
Yeah, no, absolutely. So I think first of all, thinking about the factors that we know influence someone choosing to become a GP. So there was a big report that the college did, actually, a survey that they did many years ago, maybe 10 years ago, called Destination GP, that surveyed medical students' career intentions. And there were three things that influenced. One of them were surprising. One was exposure to general practice. The second was exposure to positive role models within general practice. And the third was not hearing negative stuff said about general practice all the time throughout training. And none of that is rocket science. We could have probably predicted that, but it was a really useful survey to be able to make the case for why we need to think about all three of those factors if we want people to choose general practice as a career. So the first one has been a bit of a challenge because we need to have enough training capacity out in the community to be able to host medical students and trainees and multidisciplinary teams. So there's a bit of a fight for people. But I think there are more innovative ways of being able to do that now that we have more technology and being able to do things in a hybrid way and be able to kind of do multidisciplinary teaching as well. So there's ways that can be done, but there's definitely a need to expose early and to see what this is, see what this world is. If you don't know it, you're not going to choose it. And then I think the second one is really quite hard because I don't know if people feel very positive at the moment. So being exposed to positive role models can feel like a bit of an ask. I used to feel really acutely aware when I had medical students sitting in with me and I was having a really bad day. Duty Dr. J. Craig Miller, just thinking I could see this job far enough. And I've got medical students sitting in with me, so I'm feeling, to be honest, like a destination GP. It's kind of bringing in my years. And it's really, really hard because you also need people to make an informed decision. Like the job, you don't want to lie and say, oh, this is really easy, you'll always go at 5 o'clock. So you want to find ways of being able to say, this has the potential to be the very best job in the world, and this is how we make it manageable in our practice, and these are the things that we hope to see in the future. So I think there's something about positive role modelling, obviously. And then the absence of negative metric is a really difficult one because we've got very little control over that. Universities have some control over it, as in it's helpful, I think, in on day one of the course that isn't an announcement to the class that says we don't make GPs here, for example. And you know, and also just reminding people that there's duty of a doctor is not to be disparaging your colleagues, you know. So there's some stuff I think that we could probably use a little bit more to encourage people to be kinder to each other. But I think, you know, the whole idea of having more highly functioning interfaces and good interface groups, bringing consultants and GPs together to share decision making about designing patient pathways and understanding each other's roles and remits and helping each other with clinical decision support, all of that has fallen away because we're so busy working in silos on our computers all day that we don't come together for joint learning events or into specialist interface forums. We need to find a way of doing that again. I think we urgently need to find a way of doing that again. So I think those three things influence career choice. In terms of making people feel enabled and empowered throughout their undergraduate courses, I think inclusion health is quite variably covered. You know, and I think there's a recognition that in an ideal world it would just be a golden thread running throughout the undergraduate curriculum in recognition of the fact that this is core NHS work, rather than maybe an optional extra that people can kind of go to and maybe miss on a sunny day, which is also the case in GP training, to be honest. Inclusion health is not well enough covered. Karen is doing some great work on creating resources around ACEs and raising awareness around ACEs, and medical students are really keen to hear about the social determinants of health, about how to become a clinician advocate, about what the role of a GP could be in improving the lives of patients in the communities. It's a lot of the reasons why people choose to become a GP. So we should be making much more of their passion and enthusiasm at a young age, because what we know is that medical students start off with a lot of enthusiasm and passion and idealism, and as they go through medical school, they lose their empathy. And they also start to other people a lot more, people who are not like them. And it's sad, but that's just what medical school often does. So we need to change that as well. And I think all the things that you're talking about, getting involved with third sector, people going out, hearing seldom heard voices, all of that just ignites that interest and makes people think that's the kind of medicine I want to do. So I think all of that would be great. But there are lots of great resources. We could probably do more to share them across the different medical schools and across the different training programs as well. And I know that some work is going on within NES to do it for GP training, for all GP training. But for undergrads, there's probably also just some easy networks that could be established just to share ideas.
You're probably you're almost finished. Prerogative to ask the final question. So next week we have a thing called the general election. Accepting that the NHS is the whole issue, and you did mention that part of your role is as a senior medical advisor to the government. You mentioned some of the issues that are being discussed at government level, such as population health, inequality, and continuity. I just wondered if you could maybe give us some insights into some of the other current hot topics in government that you're involved with in terms of health. There are any other ones that
I mean, there are quite a few.
you want to pick your top three.
But I guess if we're thinking about the stuff that's very relevant to us here within the general practice division, the hot topics are the contract, phase 2. What does that mean? What does that look like? What we learned from phase 1? You know, there's a lot of interest in how well or not that is going, and the demonstrator sites that are testing implementation of parts of the MDT and learning from that. So there's a lot of time taken up with just trying to make sure that the direction of travel is right. I think there is a lot of focus now on growing the GP workforce, which I think is really positive. So there's a big piece of work looking at how do we retain our existing workforce and how do we recruit into the profession and how do we make general practice an attractive career, including kind of postgraduate opportunities like fellowships. So that's a hot topic. Health inequalities is a hot topic, I'm glad to say, otherwise I feel what's quite big. So yeah, there's a lot of specific projects that are going on around addressing health inequalities and enabling general practice to do things differently. And actually, continuity is the other one that I think is being discussed quite a lot. Now, of course, there are lots of other things that are being discussed. That's just me pick 4 or 5. So if I've missed one, it's not because it's not being discussed, it's just that I forgot to mention it. But within the general practice division, they are probably the most common discussions that I'm involved with at the moment, I would say.
That
Thank you very much. I think I'll hand over to Amy just for some thanks before we give the usual round of applause. You're so good, you don't like.
So first and foremost, thank you all for coming and for joining us online. It's been a very thought-provoking evening. I've written loads of next year appraisal. So that's started. I'm going to start my program. So thank you very much for coming, and for those who asked questions as well. It did mean feel that they got a bit lively at the front nose, which I'm not sure is good. But thank you boys for hosting as well. Particular thanks to Kirsty and Gillian from RCGP Scotland, who have done all the work for this evening, and the staff at Malmaison for the food and and specifically, obviously, a huge thank you to Carey for coming up this evening and entertaining us. I mean, you can say what you like. We do have a little time of our appreciation.
I haven't made a cake.
Very kind of. Thank you very much.